Start.
Coming, sir.
Yeah.
Yes.
Come. Start. Go to the next slide.
Good evening, all. Today's first case is a case one. A 77-year-old male came with complaints of swelling in the front of neck since 1 year. Inside is onset, progressively increasing size and not associated with pain. No history of difficulty in swallowing or breathing. No history of change in voice. No features of suggestions of hypothyroid and hypothyroidism. No medical comorbidities, no history of radiation exposure to head, neck, or chest. Status post hysterectomy 30 years ago. On
Stop.
exam,
Wait. Nikita, have you listened to his history carefully? Nikita, are you
Sir?
there?
Yes, sir.
Did you listen to his history carefully? He
Yes, sir.
says that insidious in onset and slowly progressing, but it has attained 3 times its size over the last year. Do you call that in slow progress or rapidly progressing?
It's still slow progressive only, sir.
3 times the size in 1 year, and you call that slow?
Uh, Sir, but rapidly supposed to happen within few weeks. It's the time, not the
Uh,
size, I think, sir.
Praveen, what do you think?
Sir, not a very rapid, sir.
See, we have to take in terms of what kind of a swelling which is increasing. It is a thyroid swelling. Generally, thyroid swellings are very, very slow growing.
Slow growing.
Okay, so in 1 year, if it has tripled in size, means it is rapidly increasing.
I'm surprised you guys are talking, like this.
Sir, Guru Shantapa sir has joined, sir.
Guru Shantapa sir, good evening.
Good evening. Good evening.
Very, very honored for your presence, sir. Very good. Sir, your
Okay.
opinion, a swelling in the region of in the front of the neck, which has tripled in size over the last year. Do you call that slow growing or rapidly growing?
Yeah, if she has mentioned tripled, then it has to be like a fast growing only.
Yeah.
Even though duration is 1 year.
Correct.
That's
So,
why when they present, the best way is not to get involved in such statements.
correct, sir.
Like triple, doubled, 4 times. It has increased in size last 1 year, to be on safer side, so that discussion will continue.
Continue. Okay. So that is what we always tell you, that you just say that it is increasing in size at a either a rapid pace or significant increase in size over the last 1 year. So that will be a non controversial statement. Okay, go to the examination.
On examination, patient moderately built and nourished, no eye sense. Local examination of neck. On inspection, a trend cause 8 centimeters swelling in the front of neck, extending to the left side in thyroid region, and surface appears to be irregular. Swelling moves with deglutition, not moving with protrusion of tongue. And skin discoloration present over biopsy site. Prominent neck veins noted over swelling. On
Likith,
palpation,
wait. You are a postgraduate. You can straight away say it's a thyroid swelling, not in the region of thyroid.
yes, yes,
You are inspecting and you are seeing a thyroid swelling. No, so you can straight away say 10 into 8 centimeters swelling in the
left.
whatever the left lobe of thyroid or isthmus or whatever. You clearly
Okay,
describe. You are a postgraduate. This is not MBBS presentation.
okay, sir. On palpation, a solitary swelling of 10 cross 8 centimeter over left thyroid region, basilated surface, hard in consistency with irregular margins extending superiorly beyond thyroid cartilage up to 3 centimeters, inferiorly till suprasternal notch, laterally beyond sternocleidomastoid muscle, medially 2 centimeters lateral to midline. On swallowing, lower border could not be palpable. Trachea deviated to the right side and carotid pulsation not felt on left side. No
Wait, wait.
palpable yes.
You yourself contradicted there. You said inferior margin till suprasternal notch. Then you are
Yes.
saying lower border could not be palpated.
Yes. Extending inferiorly, extending beyond. Okay.
Till you said suprasternal notch.
No, either it is invisible, either it is there or not there. You say once it is there up to inferior border like suprasternal notch, then you are saying inferior would not palpated even after deglutition.
Mhm. Yes.
So
So
it is
what is right?
extending beyond the suprasternal notch.
Ex-
The
yes.
inferior margins could not be either inspected or on inspection could not be made out, and on palpation also could not be made out.
Yes.
So it is becoming retrosternal. Is that
Yes.
what
Sir,
you're saying?
Either one of it is true. Which one is true, Nikita?
sir, actually, laterally, it was palpable, sir. Inferior border was clearly made out. But when it comes to the medial aspect, it is there is retrosternal extension. So when the patient is swallowing, we are able to see the inferior margin, but it's only on the lateral aspect, sir. So
No, that is what he has to clearly mention. No.
yes, sir. Yes, sir.
Yes.
Go on, go on.
Go
Yes.
on.
Yes. And no palpable cervical lymph nodes and Pemberton sign is negative.
What is Pemberton sign?
It on a hand raising it to rule out thoracic outlet syndromes.
Why? What is thoracic
Outlet
outlet
syndrome.
syndrome? What is thoracic outlet syndrome? This is how you get caught in exams. Nikita?
Yes.
Sir, on raising the hands above the head, due to the venous compression, there will be congestion of the face, sir. That is Pemberton sign. It is to show that pressure symptoms over the venous like drainage, sir.
What venous drainage?
Pressure
Exam
over
going.
what?
It should
Internal
not be
jugular
so
vein, sir.
vague. Huh?
Internal jugular vein compression, sir. On
Internal
raising.
jugular vein.
What?
Praveen? Gurushantapa sir, you will accept like this, sir, exams?
I don't know. She did not. He did not mention the movement with the deglutition. Straight away he went to lower border. They have written on swallowing lower border could not be. It moves with the deglutition and lower border is not made out. They should come together. You have forgotten that movement with the deglutition. One. And second, the
Yes.
upper extent you have mentioned beyond thyroid cartilage. Not many thyroid swellings go beyond the superior border of the thyroid cartilage.
Thyroid cartilage.
You know what is the reason? Why they don't
It
cross
is
thyroid cartilage? You have described here it as swelling is going beyond thyroid cartilage.
Praveen, what is the cause?
it's
What
Due to its
happens at the
caps-
level of thyroid cartilage? To
due to
the
its capsules, sir.
no, what do you
Please
have? No,
answer,
not
no
capsule.
answer. Whatever you know, you answer so that we can speak.
Not
If you keep
capsule.
mum, then yeah.
If there is capsule, even a capsule will not restrict it from going beyond thyroid cartilage. But there should
Strap
be a
muscles, sir.
reason. Huh?
Strap muscles are restricting, sir.
Not strap muscles. What happens to the general investing layer?
Condenses onto the.
Is it not
There
that?
is like
I think you should answer it correctly. No, just not say anything that. Sir? Kurushantapa sir.
They should be able to answer the attachment of pretracheal fascia. They should know so that you
Yeah.
can explain about thyroid cartilage and Pemberton sign. Why it grows down rather than going up. Why a thyroid swelling?
Correct.
Anatomical reason. Pretracheal fascia, where does it go? Where does it get united? What are the layers? In 4 directions, up, down, on either side. Anyone from
Praveen, can you talk about pretracheal fascia? What is it? Superior extent, inferior extent, lateral extent?
Sir, to the higher bone superiorly, so inferiorly, it's extends till fibrous pericardium in thorax.
Laterally.
Praveen,
Yes, sir.
if your answer is, if you say something goes and gets stuck with the pericardium, is it acceptable? Will it not interfere with the function of the heart? If some structure goes and gets fixed to the pericardium, logically, is it possible? Logically, forget about knowing or not knowing about pretracheal fascia. In pericarditis, what can happen to the heart? Will it start functioning less?
Yes, sir.
So if you say anatomically one structure which is unrelated with the heart goes and gets stuck to the pericardium, can it happen something like this? It cannot. So that cannot be the answer. Even if you don't know the answer.
Where does it go inferiorly? Laterally. Anyway, tell us what happens to it laterally.
Ravishankar, if you say like we need to answer, then I'll give so that they will remember lifelong. Otherwise, best way is they should go back and check and know directly from the book.
I think that is the best answer, sir, because otherwise everything we keep spoon feeding, they will forget it.
Correct.
So
Correct.
you have to now go back and tell us about the attachments of the pretracheal fascia.
In relation with the applied anatomy, for no thyroid swelling goes beyond the upper border of the thyroid cartilage.
Upper part of the thyroid cartilage.
Any thyroid swelling can go underneath the clavicles or into the superior mediastinum. It can go. So you find out the applied anatomical aspects of these two things.
Yes.
Okay, Praveen?
Yes, sir.
Okay. Carry on.
Yes.
You would have put 2 clinical photographs now before you go to investigation. Clinical. You have described, so we wanted to see the patient in a clinical photograph.
Clinical photograph idiyappa? Likith?
Sir, no, sir.
You should put when you present cases.
No, when you people are taking such an interesting case, why can't you people put up a photograph?
Neck is not a problem on the internet.
Yes.
Anyway, carry on.
Yes. Yes. And investigations. HB is 10.8. Our total counts are normal, and the TSH is normal in 0.75.
All of them are normal, no? They are normal. Go to the next one.
All of them. Yes. And ultrasound next showed a left lobe of thyroid is replaced by a large irregular multilobulated heterogeneous nodule, and this nodule shows hyper and hypoechoic areas and cystic areas and few calcific foci with increased vascularity. And it is seen extending superiorly till submandibular region and inferiorly having mild retrosternal extension, medially displacing the trachea to the right side and laterally encasing carotid and jugular vessels without obvious vascular thrombosis, and posterolaterally extending to the posterior triangle region. And few mildly enlarged bilateral submandibular lymph nodes are seen with preserved fatty hilum, and few sub-centimeter sized bilateral jugular and posterior triangle lymph nodes seen. And FNAC of the thyroid swelling suggestive of papillary thyroid carcinoma. And CECT of neck shows left lobe of thyroid shows a large heterogeneously enhancing mass lesion with few calcifications And thyroid capsule is breached with extensive local infiltration into surrounding soft tissues. Anteriorly, strap muscles are involved with loss of flat fin, and laterally it is encasing the carotid and jugular vessels and involving the sternocleidomastoid muscle. And medially, it is abutting and compressing the larynx, trachea, and pharynx and esophagus with few areas of fat plane loss. And in the retropharyngeal space, it is involving the posterior wall with probable involvement of left piriform sinus. And superiorly, it is extending above the hyoid cartilage level. Inferiorly, small retrosternal extension noted. Posteriorly, extension up to prevertebral plane seen without obvious bone involvement, and the scalene muscle sheath is abutted with loss of flat pen, and there is infiltration of left internal jugular vein and tumor extension through the vein into the vein lumen into the brachiocephalic vein, and left carotid artery do not reveal any significant narrowing, and few large lymph nodes in left upper jugular group regional lymph nodes. And this is the CT videos. The CT of the neck, sir. Contrast.
Okay.
Yes.
So Praveen, so you
Yes,
have
sir.
all the investigations. Now, how are you going to manage this patient?
Sir, preoperative fitness of the patient to be checked. Sir. Diagnosis confirmed now. To assess the patient fitness, we have to do tests. Sir.
Is this the description of the thyroid on this ultrasound and CT scan? Does it fill you with confidence that you're going to operate on this patient straight away?
Sir, complicated, sir, but we have to stabilize the patient and do the surgery, sir. Plan it.
Praveen,
No.
Yes, sir.
have you heard of non-operative management of a surgical case? Have you heard of?
Thyroid, sir.
No, in general, I'm asking,
Yes,
not
sir.
in
Yes,
thyroid.
sir.
In
Yes,
general,
sir.
there is an entity called a non-operative management or treatment for any
Yes,
disease.
sir. Yes, sir.
You know
Yes,
about this? Okay.
yes, sir.
And when the questions are asked for any surgical disease, even not operating on a given patient also is a type of treatment. You understood?
Yes, sir.
What are the problems that you think it is going, that you're encountering here? There's so many things on the CT and ultrasound which makes you worried.
Yes, sir. There is IGV invasion.
Yeah, I
and
think no,
carotid-
Praveen. See,
Sir.
Dr. Ravishankar is not asking you what is the treatment for papillary CA thyroid. He's not asking. He is asking for the plan of treatment for this case, which you have presented with all imaging report. For this case, he is asking.
Sir, in this case, you can do debulking total thyroidectomy.
Is there any
Followed
procedure
by-
like that in a thyroid? Is there anything like that?
Debulking is only for CA ovary. There is nowhere there is anything like debulking. Probably in GIST also, but mainly debulking is spoken for CA ovary.
Yeah.
But it's very extensive cusp of thyroid can
Okay, with these findings, whatever you have given on CT, still you think it is papillary CA thyroid or something else? Can a papillary CA thyroid give all this picture, what you have mentioned, intravascular tumor thrombus infiltrating in the mediastinum. Strap muscles are involved. Sternocleidomastoid mustard is involved. So, do you think still it is a papillary CA or something else?
See, Praveen,
It can
what
be
is the age of
yes,
the patient?
78 years, sir.
77
Ah.
years.
Yes.
What is
So
what
you
is
know
the
that also.
problem? What is the problem? What, as sir is asking, what is the diagnosis in this patient? Nikita?
Sir, what are the other malignancies of the thyroid? Other malignancies,
It
other
can be
types.
anaplastics.
Not it can be, it is
Yes,
it is
it is
anaplastic.
anaplastic.
Hmm. Nikita?
So now the question is, if it is for anaplastic cancer, what is the treatment in thyroid?
So there is only palliative treatment in
Palliative
thyroid with
treatments.
such extensive involvement as currently, sir,
Not
Because the
currently. Don't use
prognosis
that
is
word
poor.
currently.
for the
Because
patient. And
currently there is something else. But what is the accepted line of treatment?
palliative care, sir.
Palliative, sir.
Is the patient having any respiratory difficulty?
No, sir.
No, sir.
Is there any role for doing a tracheostomy or doing an hystemectomy?
Not currently, no, sir.
Not
No, sir.
currently. But now we'll come to what is the current management now or the latest management. What is the latest management? I've spoken to you about it before when I did the thyroid class. What is the latest thing that is coming on which can render these tumors operable at a later stage, in a certain number of patients?
Sir,
Nitya,
Targeted therapies, sir. Like
what is that?
wait.
d- all these dabrafenib, BRAF mutation. I mean, the drugs that will
Tyrosine kinase
tyrosine kinase TKIs inhibitors.
inhibitors. Yes. Not that we don't know how much each of them will respond, but you have to go for the higher end tyrosine kinase inhibitors. It may be all the treatment that is may be required for this patient. If in case there is good response, at later stage you may consider doing thyroidectomy if there is good response. But generally, as of now, the anaplastic carcinomas, it's only aimed at reducing their symptoms and prolonging their life expectancy, not with an aim to cure or anything.
Yes, sir.
Niranjan? Hello, Niranjan.
Yes, sir. Yes, sir. I agree.
Gurushantapa sir?
Yeah, I think he should not present this as a papillary CA thyroid after that CT report.
Correct.
He should
Correct.
have given the diagnosis of, sir, even though FNAC is papillary, because of following reasons, I think it is anaplastic cancer.
Yeah.
That should have been his answer. And
Yeah.
he should know anaplastic, how it is different from other well-differentiated cancers. You know what
Praveen,
is
is there-
de-differentiation, Praveen? De-differentiation.
Anyone can answer. Praveen, if he knows, otherwise others. What is de-differentiation?
So where it specialized cell loses its characters and gets to less specialized forms, more primitive state forms.
Praveen, Salpa, when things, even if you are not read, if you don't know, you should analyze that word itself. Differentiation is what? Coming into a specific cell.
Specific.
Okay.
Yes, sir.
Yeah, differentiation. That is papillary CA, follicular CA, medullary CA. They are all well differentiated or differentiated cancers. If I say de-differentiated, means which was differentiated earlier, it has become de-differentiation.
Differentiated.
You got the point.
So,
So, and you can explain his duration also. So many years, but increase in size last one year, 6 months, whatever. So, which was earlier a well-differentiated cancer like papillary, by imaging it is involving so much, so it has turned into a de-differentiated cancer. There is a
yes.
definite entity in thyroid. It is called a de-differentiated cancers of thyroid.
So from the
So,
outset, you've been making mistake. I've told you that it is rapidly growing, and you said it is not so rapidly growing. As Niranjan very clearly said, thyroid tumors are not generally associated with sudden increase in size unless there is hemorrhage into the, either it's a cyst or a tumor. So they are generally not very rapidly growing, but if they increase in size by 3 times over the last year, as Guru Shantapar sir said, it might have been a well differentiated, let us say here, because it said papillary carcinoma, which has de-differentiated over the last year, grown very rapidly and reached this present size, infiltrated everything. So all of these things had to give you a clue. So whenever, don't just go by what is written in the end of the diagnosis. You have to use your brain to analyze and then come out with the proper correct answers. That shows how you are analytic about things and not just following whatever is written in the diagnosis.
And
Have
when
the
you said debulking, what was your thinking? So after, how much debulking you will do? Where will you stop? And what will you do next? So
and why
if
will you do
answer,
it in the first
yeah,
place?
yeah.
Why
So
will you
that
do
is
it?
what. So that is what. If you have answer to that, you will have you can like probably would have known the correct answer here. That it is a inoperable tumor there.
Praveen, if you attempt to operate on this patient, you will lose the patient on the table because there will be so much bleeding, it's unbelievable.
Is there
And for
any
what?
role for, yeah, is there any role for radiotherapy, Praveen?
Sir, in this condition, we cannot give, sir.
Why?
It will require huge doses to
No, answer
be
is,
accurate. Yes.
Praveen, answer is, and this is an undifferentiated tumor,
Undifferentiated.
Baba. It's
Yes, sir.
a anaplastic carcinomas. They do not respond to radiotherapy. That is the answer. They don't, they were trying with, adriamycin, cisplatin, and other, these chemotherapy with very sort of marginal response. But with the advent of the newer TKIs, there is some hope. Again, as of now, it is not, as if we are going to cure them or anything, but you may be able to reduce the size and increase their, sort of, what shall we say, lifespan. So that is, as of now, that is all there is. The only operable anaplastic carcinomas are the ones which were operable in terms of surgical, on the ultrasound and CT. And then when you resect them, you send them for histology and unfortunately find out it is an anaplastic carcinoma. They are the ones which you have surreptitiously operated. That's all. Otherwise, if you have clinical suspicion, radiologic suspicion, or histologic suspicion, you are not going to attempt any operative treatment unless they have respiratory obstruction, in which case you do an hysterectomy. Followed? Don't make mistakes of saying debulking, operation, and all these things. Pre-operatively, I will assess all these things. All those things are totally redundant. That shows you are not analyzed the whole thing at all. Gurshantapa sir?
Ravishankar, Praveen, you are hearing, no, whatever he said?
Yes, yes, sir. Yes, sir.
Okay, okay. See, after presentation, what I can read your mind is, the final FNAC report was papillary CA thyroid. Okay, so you have fed your brain with that diagnosis, papillary. So you are mentioning the treatment for papillary CA thyroid, not for this particular case. That's where you have gone wrong. If the question is asked, what is the treatment for anaplastic carcinoma? If the diagnosis you would have made and anaplastic, you would have mentioned probably there is no active treatment required because anaplastic carcinoma patient's lifespan will be in terms of months, 6 months or 1 year. Okay, so that is how we went outside. So it's a case of either a de-differentiated, well-differentiated cancer, most likely, or de novo anaplastic cancers.
Correct.
So most of the anaplastic cancers are the de-differentiated tumors. So if you read de-differentiated tumor, there are two types. One is well-differentiated, which is changing into de-differentiated. with this patient with a typical history. Second will be de novo. From the beginning itself, they are de-differentiated cancers. These are the two variants in thyroid.
Correct.
Okay, so your
And-
case fits into de-differentiated cancer. So
And
if
you
you
should
by
have got
chance
the
take a
clue.
big chunk of
Sir, when sir asked at thyroid, most cancers stop at, or most thyroid swelling stop at thyroid cartilage level. If it has gone beyond, are you sure if it has gone beyond? And why is it gone beyond? You should have then got the clue from sir, because he was hinting why, that it is not a differentiated thyroid cancer. I think none of you took the clue. So in exams, this is how examiners give you the clue. You have to be smart enough to pick it up. Alva sir?
again the questions too, which when I took DNP Ravishankar, this was the question asked, and I could make the examiner happy at Hyderabad. You see, when do a thyroid swelling go beyond upper part of the thyroid cartilage, and when do a thyroid swelling comes over the chest wall? So for both the questions, when a thyroid swelling infiltrates the deep cervical fascia, that is pretracheal fascia, when it infiltrates, then on either side it will go abnormally. Otherwise, because of the anatomical reasons, no thyroid swellings below go above, up thyroid cartilage, below, over the chest. They go into the mediastinum, not over the chest. So to come out like this, it has to infiltrate deep cervical fascia, and that should be your answer. And the third one, in your presentation, you mentioned it is mobile, no? Mobility you mentioned somewhere, I saw that. With this description of imaging, this swelling is a fixed swelling in the neck, looks like, the way it is going beyond.
So that is why in the AJCC newer, this one, the lot of stress is given to extrathyroidal extension, which is, they have now given up the using of the AJs, AMIS and the matches, what shall we say? They are all used to grade the tumor or
scoring system.
scoring systems. So now they have gone
It is
beyond
called,
that.
Ravishankar, it is called a categorization of thyroid nodule. You should categorize with those scoring system into low and high. Categorization of a thyroid swelling.
So lot of stress now is given to the extrathyroidal extension and presence of lymph nodes, of course. Those are the two important things. Okay, so I think the lesson in this particular thing is you have not understood the whole picture, not correlated clinically and radiological findings, and you were just going by the, as sir said, going by the FNAC report, which I think is a red herring. So you should have taken the fact that the patient had a long-standing thyroid swelling which has grown very rapidly over the last year, and then when on clinical examination it is gone beyond the anatomic confines of the pretracheal fascia, which means it is infiltrating that, and third, on the ultrasound and CT has gone very clear picture that it is a very rapidly growing and infiltrating tumor. So all of this should have told you that this is a de-differentiated anaplastic carcinoma, hence no thyroid, no surgical treatment is possible. So that you have to analyze it this way. Okay.
Yes,
Niranjan, anything to add?
No, sir. No, sir.
Gurshantappa sir, shall we move to the next one, sir?
Yeah. Just because you stopped at imaging, is there any role for MRI here? When do you ask for a MRI neck and when do you ask for a CT neck in a case of thyroid swelling, which both of them we don't do often? Simple USG should be enough, but when do you ask for CT? When do you ask for MRI in a thyroid swelling?
Nikita, do you want to answer that?
Sir, CT, in case if you're expecting any vascular involvement, sir.
Okay.
But MRI, usually we don't ask, but until we would like to see any cranial extension, sir. But I'm not 100% sure about it, sir.
Okay, to make it short for all of you, when a disease is spreading anteriorly, with lot of nodal disease and a vascular involvement, the imaging of choice is CT scan. If the disease is going posteriorly into the prevertebral space, if you are suspecting, with all those clinical signs, if you are suspecting that it is more of a prevertebral disease extending posteriorly, the imaging modality would be MRI, just to make it simple for postgraduates.
Yes, sir.
Okay.
Yeah. So
Yeah, what was done for this case?
CT they have done. CT report he has mentioned. CT, no, this is Praveen.
yeah, see,
No. After CT, what was done? Anta?
Plan.
How did you manage? Or still being managed or planned?
Sir, at present, patient came with fever and upper respiratory tract infections. So symptomatically for treatment was.
No, but
no,
for
what is the plan
this,
of action, man?
Uh,
What has Swaroop decided?
no, but was this patient being planned for surgery?
no, sir.
No, sir. No intentions of operating, sir,
Okay.
because as she doesn't have any symptoms after the
Plan,
CT, it's decided not to operate.
Operate.
correct. But what is the no other treatment?
Yet to
Not
discuss, sir.
not referred to Swaroop.
Not yet, sir. Not yet.
So you should do that.
Yes, sir.
Okay, right.
Nikita,
Yes, sir.
Nikita.
Yes,
Yeah.
sir.
Here all of us are giving a clue that it is not a case for surgical treatment. Am I right?
Yes, sir.
Okay. And we heard also in the discussion that radiotherapy, that is what we mean is external beam irradiation. Also a not suitable treatment for this particular case. Am I right?
Yes. Yes, sir.
Okay. Any other options in CA thyroid other than these two modalities? So that we can try fitting that modality of treatment in this particular case and have a discussion. So what are the other modalities?
Um,
In general, for any cancers, what are the modalities?
so chemotherapy, radiotherapy, and
Chemotherapy.
yes, sir.
Surgery. Okay. Now left is chemotherapy. So have you read anything about role of chemotherapy in CA thyroid?
Yes, sir. That was the
Is
targeted
there any
therapy, sir.
role? Is there any role? Do they respond, whether it is partially, completely? Do they try? Is it being given chemotherapy in CA thyroid? Doesn't have a much role.
Yes, sir.
Chemotherapy also doesn't have much role. Any specific modalities available for CA thyroids? Other than this routine treatment for any cancers, anything specific pertaining to CA thyroid in the treatment aspect? You should be able to answer this.
Answer.
Yes, targeted therapy, sir, but
What?
tyrosine kinase inhibitors.
No. Palliative means what?
Targeted
Targeted, sir.
therapy.
Targeted
No.
therapies.
Immunotherapy, target therapy, they're all theoretical for CA thyroid. What is the established, accepted modality of treatment other than surgical treatment for thyroid cancers? I'm surprised. Why are you not mentioning I-131 ablation?
Sir,
I'm asking in
because
general for CA thyroid.
yes, sir.
In general, okay, that is
Radio
available.
ablation. Yes.
Can that be fit into this patient? Can you give I-131 ablation for this patient without doing surgery? Can it be? Yes or no?
He is
Mm,
given the
no,
answer
sir.
himself. He has
No.
given the answer. He is just asking you to
Yes
say the
or
answer.
no?
He's already given the answer.
No,
What is
sir.
it he's saying?
You
What is it
cannot
he's
give.
saying?
You cannot give I-131 ablation for this patient.
Why
That also
you
cannot
cannot?
be given.
Why you cannot?
Why
give?
now? You answer that. Why now?
Sir,
And sir has already given you the answer. What
so
is it he's
2
saying?
it won't respond to it, sir.
Why? No,
Well,
that
thyroid
is
clinics, they do
obvious.
respond, no?
Did
They
it
do respond.
You said something. Yeah, go on.
undifferentiated tumor, it won't respond.
Very
Dedifferentiated
good.
tumors will not
One.
take up uptake of iodine will not be there. So it is useless to
Okay.
give radioiodine therapy. See, the principle of giving radioiodine is it is what? It is brachy or teletherapy. What
Brachy,
is
sir,
brachy?
from internal.
What is brachytherapy?
which is
What is teletherapy?
brachytherapy. Radioactive material is close to the tissue, whereas teletherapy is the radioactive. I mean, radiation is sent from a
External
distance, sir,
thing. External
externally. Yes.
thing. So this will be a form of brachytherapy,
Break.
but that is only on the basis that the iodine is uptaken by the normal thyroid tissue, and
Yes,
then
sir.
the radiation works on that. But here they are all dedifferentiated, so they will not pick up iodine. So there is no point giving radioiodine therapy.
Yes, sir.
See, I have already been telling you this, that only recent, the recent literature says that there is some response to the more newer TKIs. So they don't go with the impression that they are all, game changers. Not at the moment. They
Yes.
are actually game changers as far as the recurrent, papillary and follicular carcinomas, and to some extent with medullary carcinoma. But as far as anaplastic carcinoma is concerned, it has not yet come to that stage. But there is some response. That's all. Okay. Go to
So
the
in
next case.
one more scenario, huge tumor, papillary CA, patient not fit for surgery. So can you give radioiodine at that point of time?
Sir?
See, because of dedifferentiation, radioiodine will not work. Suppose it is papillary CA, large tumor, extensive tumor, and patient cannot be operated because of lack of fitness or whatever reasons. Can you give radioiodine at that point of time?
Sir, then we can actually go ahead with the total thyroidectomy, and for the remnant
No,
tissue,
patient is not fit.
Not fit.
not fit. Okay. Okay. Sir,
You
even then we
please,
can't give
please
any of
understand the
toxicity,
question.
sir. Yes.
Understand the question before answering. Just don't blabber anything. He told you very clearly patient is not fit for surgery. What will you do?
Sir, low dose of iodine 131 you can try, sir.
Why low dose?
See, there is nothing like low dose. If you give low dose, it will not be
Therapeutic dose.
effective. You have to give therapeutic dose in such large tumors, then the therapeutic dose required will be very large. And probably it is not theoretically or even practically feasible to give such a large dose. So
More
then
than
eventually in that,
250,
so
more than
eventually in that
250
case also,
microcuries.
eventually in that case also, it will not be very effective, or it cannot be given. Simple answer. And also such a large extensive thyroid, the swelling will stay back, it will not go away.
Okay.
Right. Go to the next case.
Next case. A 56 years female came with complaints of upper abdomen pain since 6 hours, sudden in onset, intermittent in nature, moderate severity, non-radiating, and aggravated after taking food, and progress in severity, no relieving factors. Complaints of vomitings, 5 episodes since 4 hours with food particles as content, non-bile or blood tinged. And history of loose stools and vomitings 1 week back, and no history of fever, chills, and altered bladder habits. Patient passed stools in that morning and not passing flatters from then. She is a known case of diabetes, hypertension, hyperthyroidism, and rheumatic heart disease on medication. Also a known case of CA endometrium, status post open abdominal hysterectomy, and with 6 cycles of chemo and 25 days radiotherapy.
Nikita, are you okay with this presentation with respect to description of pain?
Not completely, sir, but
Oh, so if you are not completely, why? Can you complete it?
What else do you want to know? Go back
Go
to
to
the
the
history.
go to the pain.
type of pain, sir. First and foremost thing, and
He has written no intermittent in nature.
no, sir. I mean, any description about the pain type, sir, like dull aching, twisting, or
He has
burning.
given severe pain. No, moderate severity means it will be severe pain. Dull aching will be just mild pain. Praveen, anything?
Abdominal pain. What else do you want to know? He has given most of the things.
Sir?
Radiation, no?
He
Radiation to
mentioned
back.
Mentions
Radiation.
non-radiating, he mentioned.
Okay.
Any back pain? It need not be radiating. Sometimes there can be back pain also associated. Upper abdominal pain. Correct or no?
Yes.
Yes, sir.
Yes, sir. Yes, sir.
And what is that progressed in severity? Is there something like that progressed in severity?
Like it started with a like it's progressive, sir. That's what he meant.
That is what
Pain.
whatever he has put is wrong. He says moderate severity and then he has said progressed in severity. So he can tell initially when it started, it was moderate degree, moderately
has
severe
become
pain.
severe.
Now it has become severe.
Yes, sir.
And constant, if at all it is due to talking about duration.
Yes.
Okay, go to
Yes.
the thing, examination. See, Likith, there is nothing called vomitings. It's either vomiting or this one. There is no vomitings. Okay, so you
Yes.
don't keep on saying vomitings. Okay,
Yes.
it's very irritating.
Okay. On examination, patient conscious oriented, BP is 160/90 and saturation 94% per room air and pulse rate 96 per minute. Per abdomen, soft and tenderness over supraumbilical and epigastric region and no guarding rigidity distension and bowel sounds were present. And a hard nodule felt at the umbilical region and a previous midline scar present. Her total counts were 21,000 and her TS. Yes.
Hold on, midline scar from where to where?
Midline scar extending from
Where?
supraumbilical region to the supraumbilical region to suprapubic. Sir.
Supraumbilical means where to where? Like supraumbilical means is it going up to epigastrium or it is just few centimeters above the umbilicus and more of the lower midline scar extending for a
midline or
few centimeters above the umbilicus and
then extending till the
suprapubic and
yes till the suprapubic region till the pubic bone.
Yes, sir.
So you have to mention that
lower midline scar. The lower midline scar.
Lower. Okay. And her total counts were 20.
No palpable mass.
No, sir. No, sir.
What is
only
this
hard nodule?
What is that?
Only hard nodule at the umbilical region, sir.
That is also a mass, no?
Yes, yes.
You are mentioning it as a nodule. Still, it is a mass only, no? You don't know where it is coming from.
Okay.
Is it subcutaneous nodule or so skin nodule or underneath?
Yes.
Anyone else describe this nodule? Praveen, have you seen this patient?
All of them have seen.
Praveen or Nikita, describe this nodule. Hello?
Sir, there was a firm, almost 2 into 2 centimeters nodule, sir, which was
not firm. It was a hard calcified nodule kind of a thing.
non-reducible, not mobile, sir.
Is it an umbilical hernia? Is it an umbilical hernia or is it an umbilical nodule?
Sir, actually on clinical examination, it gave the impression that it was some kind of incarcerated umbilical hernia, sir. But
consistency was very hard.
consistency was hard. Yes, sir.
So it as Ravishankar sir is asking, it more look like a nodule, umbilical nodule.
Why am I asking that, Nikita? Why am I asking that? What is the previous history?
Carcinoma endometrium, sir.
So is it a malignant nodule in the umbilicus or is it an incarcerated hernia?
Yes, sir. It could be. There is also a possibility of nodule, malignant nodules.
if it is hard, you can't sit on the fence on this. How many umbilical hernias, even if they are obstructed or strangulated, have you seen it there to be hard?
No, Nikita, if you want to say it is an irreducible incarcerated umbilical hernia, was there severe tenderness over the umbilical
No, sir.
nodule?
No, sir, no tenderness.
Yeah, then
So it is an umbilical nodule.
most like suspicion,
Possibly not. Yes.
clinical suspicion, first clinical suspicion will be, it will be a metastatic deposit there because of her previous history. That is what you have to rule it out.
You can't just, say umbilical nodule and then move on. You have to characterize it, size, and the, the, which one, where is it, the, what shall be the plane of the swelling? Is it in subcutaneous plane, or is it deeper, tumor coming up from deep? All of these things you have to characterize, clinical examination is very important in the, as far as describing this. And is there any incisional hernia?
No incisional
No,
hernias.
no,
So,
sir.
So don't you think we have to you have to mention that, especially because you are thinking of an incarcerated hernia. So when you have an incarcerated hernia at one spot, most of the time there will be multiple defects, right?
What is it called
yes,
as?
sir. Yes, sir. Which is a defect.
So you have to mention that also.
Likith, did you mention about comorbidities?
Yes, sir. Yeah.
Okay.
Yes.
Okay, right.
Her total counts were 21,000 and LFT amylase lipase are within normal limits. Her TSH is low, less than 0.005.
Is she on any medication?
Yes, sir. She is using carbimazole, sir.
Is it important or not? You have to mention, no?
Yes. Yes, sir. She is using carbimazole tablets for the hypertension.
And still not controlled.
Yes.
Okay.
Ultrasound abdomen and pelvis suggested small bowel obstruction with an adherent small bowel loop just below the periumbilical scar tissue and small bowel wall thickening, likely reactive changes and mild reactive ascites. And CECT abdomen pelvis, small bowel obstruction with transition point at the umbilical level due to postoperative adhesive scar tissue in the right paraumbilical region. And long segment mild diffuse circumferential enhancing small bowel wall thickening distal to the transition point. And omental frac necrosis adjacent to the adherent mid ileal loop. And mild free fluid in the peritoneum, likely reactive. And this is the CCT contrast video of the abdomen.
What other things would you have expected in the CT, Praveen?
Sir, in terms of
Given the background of the previous history of surgery, what else would you have concentrated on CT apart from what is being described?
sir, due to previous surgery adhesions.
Additions
and,
already she has described.
Yes, sir. Omental deposits, nodules.
And then
Omental and
what else?
Peritoneal, sir.
Peritoneal, and then what is the common thing that we usually see?
Any recurrence, sir,
Liver
like
deposits.
liver mets
Liver
Liver
mets,
mets.
and ascites.
ascites, presence of pelvic mass.
See, we have to prompt you so much for this kind of a basic question.
See, I don't think Niranjan and I have talked about this case before, but we are both coming up spontaneously with the answer that we expect of you. So you should know this is what is expected. Okay, now with this finding, Nikita, now let us grill you. How are you going to manage this patient? You got all the investigations done, CT has been done. How will
Stop
you
there,
manage this patient?
Likith. Stop. Go to a little bit before the video when you're running. No.
Yes.
Go back. Go back. No, go back. I said go back.
Yes.
You're going forward, man. Go
For
back.
Sorry, it is not. Here, sir.
okay. Go. I will ask you to stop. Then stop. Stop it there.
Yes.
Sir, as CT suggests that the transition point or the obstruction is at the level of umbilicus, and with a strong suspicion of malignant nodule at the umbilicus, we would like to go ahead and do a diagnostic laparoscopy, sir.
No, not only. Why? If there was no malignant nodule, then you wouldn't have gone in.
We would have gone in view of obstruction, sir, but conservative, it could be if there was no nodule, it could be partial obstruction due
No.
to an adhesion.
What was against conservative management in this case? When do you manage obstructions conservatively?
What did they say? Is there a point of transition?
Yes, sir.
Then, if there
Yes.
is a point of
And what?
transition,
How has the patient presented with severe pain, which is
Severe.
progressively worsening? Total count
Yes,
of 21,000.
vomiting,
In the pelvis, free fluid in the pelvis. What are these things indicating?
Obstruction, progressive obstruction.
No,
potentially
obstruction going in for
strangulation. White cell
Strangulation.
count is high, no? 21,000.
Yes, sir.
and you're seeing this in this picture. What is happening there? There is so much of inflammatory changes around the obstruction site, and also in that area there is a nodule there.
Yes, sir.
So
So
how will you manage this patient?
Sir, we performed a diagnostic laparoscopy and
No. Before that,
before that patient
sir,
has come
before
to you
the
in
initially when the patient
emergency,
presented,
first
sir,
what will you do first?
sir,
You've been
Ryle's tube,
telling persistent pain, so you have to take care of the pain, no?
analgesic. Yes, sir. Yes, sir.
Proper
pain,
analgesia,
patient
then
is
Proper,
persistently vomiting.
vomiting, dehydration,
sir.
fluid balance.
Anal analgesics, NPO, IV fluids, and Ryle's tube, active and passive
Yes.
aspiration, urine
My,
output
my,
monitoring, and antibiotic coverage in view of the elevated counts.
And
Antiemetics also, sir.
pre-optimization of the patient. Immediately,
Yes,
I'll do diagnostic laparoscopy. It shows that you've not worked in the wards. Well, we
yes.
keep on telling you, no? What is the indication where you have to immediately shift the patient to the theater? What
If
situation?
patient is toxic, sir, like
No, even toxic patients also you have to optimize them. May not be for that long,
if
but you have to
if patient is exsanguinating and
bleeding. Yeah, exsanguination.
yes, sir.
That's the only indication to take the patient immediately to the OT. Otherwise, you don't waste much time. If you are right, if the patient is very ill, there is not much point in they will not get better with the proper optimization because they are very toxic. So you start all the things, give them oxygen, give them painkillers, put a catheter in, give fluids, arrange blood, all those things. It will take about an hour or so, and then immediately shift to the OT. But if the patient is relatively stable like this lady, you optimize them because they vomited 5-6 times, so there will be an element of dehydration, acidosis. So correct all of that. If you need to get a blood gas done, because counts are 21,000. So get blood gases done. Who is going to answer all these things? There should be a method
Yes.
method in way how you address the issue. See, not just say I'll do a diagnostic laparoscopy. That is there later. Okay. Have you done all these things now? So at laparoscopy, what will you? Is laparoscopy possible in this patient?
Yes, sir. It is possible as there
Why do
was
you say that?
there is
Why do you say
no
that?
distension of abdomen, sir. Not
Okay.
no
Yeah.
severely dilated bowel loop, so we can actually do a
Okay.
laparoscopy, and
Right.
we did it.
There were dilated bowel loops, but it was
Not
like we
severe.
had tried to decompress, and also there was a virgin territory in the upper part, in the Palmer's point, where we believe probably we can have a safe entry and see. It might not be possible to manage, but you can always see.
Yes, sir.
So what did you do?
Sir, we did diagnostic laparoscopy through Palmer's point, sir. And intraoperatively, we found that there was extensive adhesions to the previous operated site, to the anterior abdominal wall. Upon releasing those adhesions laparoscopically,
Yeah.
so a hard mass, the umbilical nodule was found to be a hard mass over the bowel. So,
Which was the transition point.
transition point. Yes, sir.
And also there was lot of dense interloop.
Sir, bowel adhesions.
The interbowel adhesions. Yes, sir.
Yeah, maybe because of previous
So, surgery,
Radiotherapy.
therapy. Yes, sir.
Radiotherapy also. So what did you do in the end?
Sir, in the end, during the adhesolysis, there were a lot of.
You didn't put up this one.
Sir?
Last video, open video. You didn't put up last one.
Yes. Yes.
Uh,
No.
no, sir. Intraoperative laparoscopic video we have put up, sir.
No, he had that intra-op video, the transition point and all that.
Oh.
So, we did, after adhesolysis,
Did you open?
perform a bowel walk. Yes, sir. To perform a proper bowel walk, we opened.
No, not to perform a proper bowel walk. We had already released the adhesions. Why did we open? Two things. One, that nodule was supposed to be probably look like arising from the mesenteric border of the bowel, either from the mesentery or from the bowel. We couldn't make out and we couldn't separate it. And it was like if we had to cut, there will be a tear there in the bowel. So,
Yes.
and that is one thing. Majority of the 90% of the adhesions we had released, and there was a transition point, and there were some other adhesions also, interloop adhesions, which was probably not safe to release it laparoscopically. That's why we made a small laparotomy in the umbilical area to deliver the disease segment nodule, resect the nodule, and close the rent, and also release the interbowel adhesions, which were not safe to release it laparoscopically. That is what we did.
You didn't have to resect the bowel, Niranjan?
Illa, sir, it was only from the mesenteric border where we excised, and there was a only tiny 1 centimeter opening, not even 1 centimeter. So we had just closed the rent and excised that nodule. That is what the photograph is showing.
Yeah. So what did the nodule show? Histology?
Normal calcification only, sir. No metastasis.
Calcified nodule.
No malignant cells.
Okay. Post-op recovery?
Sir, on second post-op day, on first post-op day only, post-op day one, clear liquid started, sir, and then on the night, she again started having abdomen distension. So we kept NPO and again put Riles tube and connected to back, sir, and total around 200 ml of bile came, sir.
Okay.
And next day morning, at that time, pan and perinam all given. And next day morning, she again vomitings all stopped and again started clear liquid, sir, and removed
Why?
rails too.
No, no, no. Before that, why did we start again liquids? Patient had bowel movements,
Yes,
spontaneous
yes,
started to pass flatus and started to pass motion.
yes.
Yeah. So then we really removed the rails tube, allowed soft diet and center home on day 3, na?
Day,
POD.
Thursday, Friday, sir. Yes, sir, day 3.
Yeah.
Nikita, do you think this would have settled on conservative treatment?
No, sir. It wouldn't have in view of the
Yeah, it
progression
is.
of the patient at the same time due to the proper transition point, sir.
Correct. It wouldn't have settled. And other thing is, even in contrast has been given, and the contrast would not, normally it will either, completely relieve the obstruction, or it will show you a point obstruction, which it has done in this case. So you have operated. So
Yes.
there's no role for conservative treatment in this situation.
Yes, sir.
But you have to say that confidently. That is the thing. That is why I asked you.
Yes, sir. Yes.
Okay. So I think 10, 10, 10. So we'll stop with these two cases.
ಗುರುಶಾಂತಪ್ಪ ಸರ್ ಇದ್ರು ಅನ್ಸುತ್ತೆ ಅವ್ರದ್ದು ಕಮೆಂಟ್ಸ್.
Sir, Gurshantapa sir.
ಇಲ್ಲ ಇದೀನಿ ಬಿಕಾಸ್ ಯು ಪೀಪಲ್ ಆರ್ ಟೆಸ್ಟ್.
So
ಎನಿವೆ ಬೋತ್ ಅಲ್ಲ ಸೆಕೆಂಡ್ ಕೇಸ್ ಇಫ್ ಇಟ್ ಇಸ್ ಅ ಹಾರ್ಡ್ ನodule in the umbilicus, what we are thinking is a Sister Joseph nodule, like a deposit
correct.
in the umbilical plate. That's what
Correct.
the answers we expected from the candidate.
Yes, sir.
And you would have mentioned few points pertaining to the clinical examination of that nodule, which you
Yeah.
did not highlight. Nodule, clinical, like
Right.
leg raising test, it remained same. Mobility stopped after that. There is no cough impulse. So all those clinical findings should be presented for umbilical nodule. Because the questions were, was it a hernia? So if you say there are no cough impulse, and on leg raising it becomes more prominent, hernia is ruled out. And hard inconsistency, non-tender. So those points should be mentioned. And in the investigation modality after CT, still the FNAC has got a role over the nodule. Once you have imaging shown that it is a parietal nodule without having anything connection with the intestine, so FNAC definitely is one of the investigation to rule out that it is not a deposit like
Correct.
in the examination. And you mentioned laparoscopy, yes, fine, because the substantiation is remaining abdomen is normal. It is not distended, soft abdomen. So these and there can be some questions on Sister Joseph nodule, which is the commonest malignancy, intra-abdominal malignancy, which can present as a nodule. It is not the ovarian malignancies which are common. So you should know answer for that. Sister Joseph nodule, commonest.
And
Commonest.
mechanism of that nodule. Yeah.
Nikita, which is the commonest malignancy presenting as Sister Joseph's nodule? Huh?
Sir, ovarian malignancy, sir.
Not ovarian.
Gastric
He's already
nodule,
told
gastric tumor, sir.
CS stomach.
Yes, sir.
And what is the mechanism? You don't know.
Sir, yes, I know this, sir. Venous drainage, sir. Around the umbilicus, there is a portal
Portal venous. Portal
portal venous
systemic.
drainage.
Portal
Yes, sir.
systemic.
Portal systemic anastomosis.
Not shunt. Portal systemic anastomosis. Yeah. So that is the reason.
Tumor cells drain through the gastric into the portal system via this. So through the portal system into the systemic via the umbilical vein, sir. So that is the reason they get deposited there.
Nikita, from which book you have read about this? What you are talking now?
Sir,
Which book? See, we are talking about an umbilical nodule. We are not talking about a vascularity around the umbilicus in portal hypertension. Portal hypertension is a vascular disease. So here, if you are talking about a cancer deposits in the umbilical area, so can it be a lymphatic origin or a vascular origin?
Lymphatic origin, sir.
Lymphatic origin. Then find out how a lymphatic, if it is a lymphatic origin, how GA tract cancers can come to the umbilicus through lymphatics. Even if you are not ready, if you don't know, have a logical thinking. So it cannot be a vascular associated nodule. It has to be a lymphatic associated nodule in the umbilicus. So how is that GI problems inside the abdomen, whatever, whether it's a pelvic organ or a GI tract, how can it get connected to the umbilicus through lymphatics?
Yes, sir.
Think logically. Praveen, can you answer that? Nitya or Sanya?
What is a method of CA stomach spreading to liver through lymphatics? CA breast. CA breast, can it go to liver? Hello?
Answer,
Yes, sir.
answer.
Yes or
it can
no?
go to liver.
Yes, sir.
So is it always hematogenous spread or maybe some other reason also in CA breast, liver involvement?
Could be like a systemic lymphatic spread, sir. Like
Other than hematogenous, can there be lymphatic spread from the breast to the liver?
And if so, how?
Ravishankar, let these two things to be homework for them.
Yes, sir. Homework.
Huh?
We can't
Okay,
give them all
Yeah,
answers.
find them. Anyway. Okay.
Please put it up in that Sagar Aster group. Sir is also there.
So,
Gurushanta
sir is
Pasar. He'll
also
also
there.
see.
You need to be, tomorrow it should be there or tonight.
All these
Yes.
and also the thyroid questions which Sir asked.
yes, sir.
Pretracheal
Yes.
fascia, Pemberton sign.
So I think both cases, if the ward rounds, I think your answering is not been very satisfactory. You need to improve significantly. Niranjan, your final comments and Gurushanta Prasad comments after that.
Sir, same sir, good discussion, but they are still not up to the mark for final year examination.
Gurushanta
There are
Prasad.
lots to improve.
Yeah, postgraduates should have a free flowing presentation with good clinical examination findings. Area automatically will come once you bring us for the discussion. Definitely, it will have a good discussion. But if you don't have a good clinical presentation, then you will be stuck there only. Anyway, good cases. Both Niranjan, good cases. Huh? Both are
Thank
good
you.
cases. Okay.
Thank you, sir. Good night.
Thank you.
Good night. Thank you very much, sir, for your input.
Good night.
Good night, Niranjan. Good night, everybody.
Thank you, sir.